Our next talk is from Katy Kuhrt, who unfortunately can't actually be with us this morning because she's had to go to theatre because of the number of people off sick in her unit. I've worked with Katy in the past. She's a fantastic young researcher who has been doing amazing work, and fortunately she sent us through a pre-recorded talk. So she's going to be talking to us on from bench to bedside, point of care, PlGF testing in pre-eclampsia diagnosis and management. Thank you, Marcus.
Can I just confirm you can see the screen?
We can see the screen, yeah.
Hello, my name's Katy. I'm a PhD student in obstetrics and gynecology registrar. As part of my PhD, which I'm just about to finish up, I have been looking at a series of point-of-care tests in acute obstetric complications, including pre-eclampsia, and I'm delighted to talk to you today about point-of-care PlGF testing in pre-eclampsia diagnosis and management. Sorry for those of you who are very familiar with PlGF, but placental growth factor is an angiogenic biomarker which is secreted by the syncytia trophoblast and promotes placental development. It has been shown to be lower in preeclamptic pregnancy, and this was demonstrated way back in 2002 by Chappell et al. In a case control study that showed lower PlGF concentrations in women with preeclampsia. Then followed a multi-center diagnostic test accuracy study which showed that PlGF outperformed other blood tests and biomarkers, systolic blood pressure, diastolic blood pressure, proteinuria, uric acid, ALT, for predicting preeclampsia, and that the PlGF result allowed stratification of the women most likely to need delivery for preeclampsia within 14 days versus those who would continue to be pregnant for many weeks. Then came the Parrot trial, a randomized controlled trial in 11 maternity units across the UK, including more than 1,000 women with suspected preeclampsia. Time taken to reach preeclampsia diagnosis was halved with PlGF testing, and maternal complications were reduced. A cost-benefit analysis published in BJOG then showed that PlGF testing costed less than standard practice, saving the NHS an estimated £149 per patient. In 2021, PlGF was then introduced into the NICE guidelines as part of NHS care. This page of the PlGF-based testing guideline shows a recommended range of PlGF-based tests. The COMPARE study compared their performance for predicting the need for delivery within 14 days and showed that they were all similar, albeit at slightly different thresholds. However, the key barrier to widespread implementation in the UK as well as further afield is that current testing was not available on whole blood, therefore requiring centrifugation and cumbersome, expensive equipment. Then came LEPSI point-of-care PlGF test. This is a fluorescence immunoassay for quantitative detection of PlGF from EDTA anticoagulated whole blood with a result in 15 minutes. It's easy to use at the bedside with no need for centrifugation of the samples, and it's very sensitive, detecting PlGF levels from 12 to 3,000. So this PEACHES study aimed to validate LEPSI PlGF against Revity Delphia Express PlGF, which is nationally recommended by NICE as the validated gold standard PlGF test. The study was performed on 242 stored frozen serum or plasma samples taken from women greater than 20 weeks gestation with suspected preeclampsia. Clinical performance of LEPSI PlGF to rule in or rule out preeclampsia within 7 days and 28 days of sampling at different gestations is shown in this table. High test performance to rule out preeclampsia is highlighted in the negative predictive values highlighted in the left two columns of the table. And there is corresponding high positive predictive value to rule in preeclampsia within 28 days, highlighted on the right two columns of the table. High sensitivities and negative predictive values reflect the clinical utility of the test as a rule-out test to determine which women can be safely sent home, allowing interventions to be targeted to those who need delivery. As you can see here, the negative predictive value for rule out of preeclampsia within 7 days is 97%, which is comparable to other validated tests. And these two ROC curve graphs show the performance for LEPC PlGF for predicting preeclampsia within 7 and 28 days of sampling on the left and right respectively. And this diagnostic accuracy presented supports testing in women up to 37 weeks, which is indicated by the blue dotted line and is comparable to nationally recommended tests in the UK. This graph here shows specifically that the point of care LEPC test, which is the dotted line in green, has similar / even slightly better test performance for diagnosis of preeclampsia within 14 days compared to the Delphia Express, the gold standard PlGF test, which is the dotted line in blue. And the strengths of this study is that it was a study sample collected from a diverse population of women in London. And it compares LEPC, as we've said, to the gold standard. However, it was taken on frozen samples, and it was important to then evaluate LEPC PlGF in a real-world setting and prospectively. And this led to the predictive prospective observational cohort study that I have just been working on in Sierra Leone. So just a bit of background about Sierra Leone. Women in Sierra Leone are 2,000 times more likely to die from preeclampsia than a woman with preeclampsia in the UK, even though interventions are available. And most of these maternal deaths are preventable and are related to delays in detection and subsequent treatment of preeclampsia. And the thought is that point of care devices, including point of care PlGF, could allow earlier detection and care to be delivered in the right place at the right time. So this led to the Pineapple study, which was looking at evaluating this novel whole blood point of care PlGF test for prediction of adverse maternal and neonatal outcomes in women with suspected preeclampsia between 24 to 36 plus 6 weeks, presenting to a maternity hospital in Freetown in Sierra Leone. And just to mention, there was a parallel cohort being recruited in Zambia, in fact, a larger cohort of about 400 women, and this analysis is ongoing. So we deliberately chose important severe outcomes. So for the maternal outcomes, we chose a composite of one or more of death or eclampsia, and some secondary outcomes based on a modified mini-Peers composite. And the perinatal composite outcome was one or more of antenatal or intrapartum stillbirth or neonatal death before discharge. And we collected these outcomes because we had a unique opportunity to do so in this setting, which unfortunately has one of the highest maternal mortality rates and stillbirth rates in the world, and in other settings has previously not been possible, hence the focus on time to delivery and preeclampsia diagnosis, because thankfully these severe outcomes rarely occur in high-income settings. This is a list of the mini-Peers outcomes, and the ones highlighted in orange are those that we found particularly difficult to collect, given the limited access to blood tests and other clinical tests in this setting. So these are our headline results, and I'm presenting here women with tests done at less than 34 weeks gestation, where the performance of the test was slightly better. So the box in yellow around the bar chart shows the two columns denoting women and babies with a normal test result, and you can see that there are no pink areas on these two bars, indicating that women with a normal LEPC PlGF had no composite maternal or perinatal outcomes. And this slide just looks at that in a little bit more detail, showing consistently with the previous slide sensitivities and NPVs for both the maternal and perinatal outcomes of 100% with a normal PlGF test. And at the other end of the spectrum, if you look at a rule-in threshold of a very abnormal PlGF at less than 12, the positive predictive value is 22% for a maternal outcome. So of those women who had a positive test, 22% of them experienced the maternal composite, which, to remind you, was either death or eclampsia. And for perinatal outcomes, this was positive predictive value was 48%. So 48% of the women with a very abnormal PlGF test had a stillbirth or a neonatal death. And given that 103 out of the 140 women with LEPSI PlGF tests had positive tests, that signifies and represents a huge number of women and babies experiencing these serious adverse outcomes. And this next slide shows that the median time to delivery, in keeping with studies carried out in the UK in PlGF, show that women with a normal versus very abnormal PlGF remain pregnant for very much longer. So here you can see that in women tested less than 34 weeks, women with a normal PlGF test had a median time to delivery of 21 days versus 3 days in women with a very abnormal PlGF. So these results we published in Hypertension Journal recently, and this is the graphic abstract that was published alongside the paper, which is trying to really illustrate the kind of clinical implications and how, as clinicians, we can use this information to take care of our patients. And the orange box is around the LEPSI results. And it just reiterates the statistics on the previous slides, which shows that with a very abnormal PlGF, 1 in 5 women experienced death or eclampsia, and 1 in 2 women experienced stillbirth or neonatal death, with a median time to delivery of 3 days, versus those women with a normal PlGF having none of those outcomes and having at least 3 weeks on average until delivery. So in this way, you can see that with a normal PlGF result, this justifies expectant management and enabling those scarce resources to be targeted to those who have a very abnormal result and are therefore at very high risk of having an adverse outcome, which more than justifies intervention like delivery, for example. Now, this kind of clinical utility of the test is currently being evaluated as part of the ongoing NIHR-funded PAPEG-UK research group, which is looking at using point-of-care PlGF to stratify management interventions and basically timing of delivery. So, for example, a normal PlGF result would justify expectant management, avoiding early delivery in settings with possibly limited neonatal resources, versus a very abnormal PlGF would indicate the need for delivery. And this is currently being evaluated in Sierra Leone, Zambia, India, and Brazil, to give a real spectrum of settings and increasing the generalizability and the clinical utility of the findings. So in conclusion, LEPSI PlGF-based testing can help to rule in and rule out pre-eclampsia and related maternal and perinatal outcomes in both high-income and low-income settings, with comparable performance to NICE recommended gold standard PlGF tests. And more work is needed to evaluate integration into clinical management pathways, which is being ongoing in PAPEG-UK. But also, just to say, in the clinical settings in the UK, even in London, many hospitals do not currently offer PlGF testing. And point-of-care PlGF testing could offer a real opportunity for these tests to be implemented at the bedside, avoiding such as happens in the hospital trust where I currently work, PlGF samples being sent across London and returning 7 days later, by which time it's really too late to help the sickest women. So thank you for listening to this presentation. I'd be very happy to take questions via email. My email address is at the bottom of the slide. Thank you so much.
My thanks to Katy for having recorded that presentation. And please do send her your questions. She's very responsive and will be very